Yes, good afternoon, everybody. Dear Chairman, thank you for the introduction, although I did not understand that much, I'm sorry, but I think that's not a big problem. So I was asked to talk about total mesopancreas excision, and do we change our standards, or do we have to change our standards? When we think about pancreas cancer and the operations of pancreas cancer, we talk about local tumor control and, of course, also systematic disease control. These are the two aims for the patient, and I will come back to that a little bit later. For us, as the surgeons, local tumor control is what we can achieve, and that's what we probably should aim at. So, when we talk about the mesopancreas, there are different approaches and different descriptions. Somebody calls it total mesopancreas excision, somebody calls it a level 1, 2, 3 dissection, we call it triangle operation. And then, of course, as the last point, I want to focus a little bit on the arterial divestment as one of the most recent developments in pancreatic cancer surgery. Why do we want to do this? Because we want to be radical locally, I already said that. We want to harvest as many lymph nodes as possible. We want to remove all the nerves and the connective tissue to achieve, hopefully, an R0 resection. And of course, at the moment, we don't really know what happens after neoadjuvant treatment, what the impact of radicality, R0, R1, is really after neoadjuvant treatment. However, the so-called mesopancreas, you can see, is described here in a scheme and here in the CT scan. This is somehow the soft tissue between the uncinate, the vessels, and everything like that. But that is exactly the problem of this definition. If we don't do this, we have a high risk of recurrence. I just want to show you some data from the SPAC4 trial. You all know that trial on adjuvant therapy. Follow-up was quite long, 43 months in these patients. And the patterns of recurrence were investigated afterwards. You all know you can have a recurrence like that. This is, of course, unfortunate for the patient. This is palliative chemotherapy. But you can also have a recurrence like this, a local recurrence. So this is something we talk about, and also how to avoid this maybe. And looking into this data, you see that 1/3 of the patients have a local recurrence alone, and 7% of the patients had a combination of distant and local recurrence. So 1 out of 3 develops a local recurrence. What is the prognosis? I just want to go back for a second. When you see this, you see that the local and the distance recurrences are shown here and here. And of course, some patients also die without a recurrence of some other reasons. And probably the local recurrence might be a surgical problem that you have just not operated radically enough. When the patient gets a local recurrence, you see the prognosis is usually as bad as for the systemic recurrences, 24 months compared to 23 or 20 months. This is not in favor of local recurrence being treated differently. You know the reason why? Because most people think local recurrence is the same palliative therapy as distant metastasis. So the local recurrence does not kill the patient. The wrong treatment of the local recurrence kills your patient. So you should approach a local recurrence whenever possible, but this is not the topic of my talk today. This is just a little side take-home message. Where do you have to look for the local recurrences? There are some hotspots in the CT scan. You can always see this along the mesenteric vessels, of course, along the aorta, along the portal vein. And then, of course, these are the so-called hotspots, again, in the mesenteric root, along the mesenteric artery. This is what we can approach surgically and where you should not have a local recurrence. If you are not radical, I showed these pictures from a patient from Heidelberg quite a long time ago already, 3 months postoperatively, unclear, 6 months still unclear, after 9 months clearly a local recurrence between the mesenteric vessels, maybe even a tumor persistence, so you have not done your job properly. What is the so-called mesopancreas? This was described in 1927 by the Mainz group already for the first time. This was more or less an anatomical study, and they tried to define what the mesopancreas is. You see, they approached some cadavers from the venous axis, and they removed all the soft tissue on the right side of the venous axis, and then this was called the mesopancreas. And when you look in the staining, you see that there are some nerves in the mesopancreas, the red tissues, and this brownish is the lymphatic vessels and the lymphatic tissue, which is also, of course, included what we know today. And then they were a little, from my point of view, going too far, because they said the mesopancreas has a holy plane like the mesorectum. Everybody was keen on that because we thought, oh, mesopancreas have a combined department that you can take away, and local recurrence is gone. This is not true because there is no holy plane. You all know that. There is too much things other than the rectal holy plane that is not comparable. The next definition of the so-called mesopancreas was by the Lyon group of Mustafa Atam in 2012. They regarded this from a surgical point of view, and they just reported this as a technical report in 52 patients. And what you see here is they were a step further. They approached the artery as the limit of the mesopancreas, shown here and also shown in the CT scan, not the vein but the artery. And I think this makes more sense, because why approach the vein and not the artery? The artery is just below the vein. And of course, these operations were done mostly for cancer of any type, and they could achieve an R0 resection in 80% of the patients, which is excellent from my point of view. And this shows you, if you are radical, you can achieve R0. So, to conclude on the so-called mesopancreas, this is a nice review 2 years ago from the Brazilian colleagues. They summarized all the literature on the so-called mesopancreas, and I think this is the important things. The mesopancreas does not exist, and the mesopancreas is most likely to be a pseudo-mesopancreas, because it's not an anatomical compartment, it's not an anatomical definition. There is no fascia, there is no avascular plane where you can just take out the mesopancreas. There are too many tight connections around the vascular structures. From my point of view, we should not talk about the mesopancreas anymore. What else is dealing with this, and what is better? This is a very nice systematic surgical classification from the colleagues in Tokyo, Yosuke Inoue. He published this in 2015, and he was dealing with all of the relevant connective and nerval tissues. He classified that very well on the right side of the mesenteric root. And what he defined is 3 levels of resection for pancreatic head resection. This is the level 1, which is shown here. This goes on the right side of the SMV and then this way down. Then you have the level 2, you change to the left side of the SMV and then go down further this way, more radical. But the most radical is the level 3, where you approach the artery sharply, you go on the artery and then again this way on the left side, take away all of the tissue. I think this makes absolute sense, and this is a very accurate definition. For this type of surgery, when you have experience, you take even shorter time and you take less blood loss, which is clearly located to the fact that you approach the anatomical structures clearly. You see the vessels, you clip the vessels, you dissect the vessels. If you are somewhere in the fat or in the connective tissue, you don't see the vessels, it's bleeding, you struggle. So it's more advisable to follow the anatomy clearly, and then you have good results with this. And what else you see is, when you do this correctly, your morbidity is not increasing, your morbidity is actually lower. So what is the recommendation of the Tokyo colleagues? Use these level 1, 2, 3 dissection techniques sensibly in the correct indications, which means the level 1 you should probably only use for benign indications, because this is not radical. The level 2 you can choose for tumors in the head of the pancreas, but the level 3 needs to be definitely chosen for any uncinate tumors or tumors that are extending to the medial part of the pancreatic head too much, and then you just need to be on the artery. Clear definition of this resection and clear view of your structures when you do your operation. And then, of course, you can improve your resection status and you end up with a situation like this. Everything is cleared out here, and this is a level 3 dissection from the Inoue classification. We have dealt with this some years ago after neoadjuvant therapy, how to approach this, and we have called this the triangle operation, just describing the technique in this little work as well after neoadjuvant treatment. We have the experience that after neoadjuvant treatment, you always have to go to the OR and take some frozen sections. If they are negative, you can approach the vessels very sharply, and you mostly spare the arteries and can perform this triangle operation, which only describes the radical removal of all the tissue on the right side of the SMA, the celiac axis, and the portal vein. And this means you have a CT scan like this after FOLFIRINOX. No radiologist will tell you what's going on here. If you go to the OR, take away everything, remove the tissue in the triangle between celiac axis, SMA, and portal vein. You can spare the arteries. You have to resect the portal vein very often, and then you have done your job very well. Another example is shown here. Celiac axis, some tissue around, SMA, some tissue around. After FOLFIRINOX, we don't know what that is. Take the patient to the OR, and again, you can do your triangle operation, take away everything here, and this is a complete mesopancreatic excision. But after neoadjuvant treatment, you don't know what's in there. Probably it's much more scar tissue than usually, not only nerves and lymphatics, but also a lot of connective tissue, a lot of fibrosis. What is the outcome of this type of operations? We have had a look at that too. The more or less long-term outcome, we have done this for Whipple procedures as well as for total pancreatectomies, and we have compared these triangle patients with the standard resections by the time we did not do this routinely. You see again, this is kind of a safe operation. Morbidity and mortality does not differ for the Whipples and does not differ for the total pancreatectomies. The only thing that the patient might experience is some diarrhea, but this diarrhea, due to the taking away of all the nerves, can be handled in 4 to 6 weeks, mostly very well by opioid drugs and things like that, all this anti-diarrhea medication that we have today. So don't be afraid of this operation. It is radical, but it is not dangerous. R0 was not really increased in our series here, so more radical, I cannot tell you at the moment. Probably it might be more radical, but I cannot prove that. It has potential advantages in this too. And therefore, we have now just started a randomized controlled trial. This is a multi-centric trial in Germany comparing conventional with the triangle resection for Whipple procedures. And this is 270 patients that are planned. Primary endpoint is the disease-free survival. And then, of course, we have all the other endpoints, radicality, overall survival, morbidity, and especially quality of life as the secondary endpoints of this RCT. And maybe then we can prove that the patient has a benefit from this triangle operation on a high level of evidence as well. Can we do this robotically? Yes, we can do this. This is how I do it work with the colleagues from Baltimore. You can approach the same tissue structures with a robot, which means you can take away all the nerve plexus, all the lymphatic structures on the right side of the SMA and of the mesenteric root. And then finally, you have the same situation with a nice triangle cleaned here or here. And this is as radical as in open surgery. So we have no concerns with the robot to do this, no compromise for the patient in terms of oncological radicality. This is a very nice series from the PISA group, from Ugo Boggi. They have now adopted this for the robotic technique. 127 they have done with the triangle Whipple. Feasibility and outcome was their endpoints. And you see, again, robotic triangle. I think this is absolutely no difference to an open operation, as radical as we know it from the open surgery. Looking at the baselines, you see, quite interesting, they are not afraid of any previous abdominal surgery. Half of the patients did have that. Also not afraid of any anatomical variations in the liver arteries, and a very low conversion rate. Of course, the PISA group is one of the most experienced robotic groups in the world, so this is not so surprising. The rest is quite standard, mostly pylorus preserving, but you need to be patient. 9 hours operation time, this is not something you want to do every day, I think. What about the outcomes? They had a certain learning curve. After the learning curve, mortality was excellent with 2.3%. And of course, again, this was done only for malignant pancreatic cancer or IPMN-associated pancreatic cancer. And I think most important, what they show is the perineural invasion, 85% of the patients. This tells you, take away this tissue, don't leave the nerve plexus on the artery, otherwise you leave the tumor behind in its perineural spread, which is present in 85% of the patients. And when you do this, you see, low here, 42 average lymph nodes harvested. I don't know what your pathologists tell you after your operations, but 42 for a Whipple procedure is quite okay, I would say. Mostly it's maybe about 15, 20, 42 tells you everything is clean, everything has been taken out. So they just conclude, nice graphical abstract, you need some little learning curve for this procedure. You should do it not with diathermy, they call it cold triangle with the robot, just go with the scissors and clip, no heat, no damage by heat in this procedure, and then you can do this and you can radically operate with the robot as open. One little side aspect, this is a study from China. This is also cost-effective, so to say. They investigated triangle yes or no in 246 patients with some kind of very sophisticated statistical method and quality adopted life years that patients gained after having this triangle operation. This is just the flow chart. They had a look at these patients with or without complications after 1 year with a triangle operation or with the standard Whipple operation. And don't want to go into details too much. You see, again, complications are less in this triangle operation group here. Pancreatic fistulas are, okay, I would say standard, but less than their standard open Whipple procedures. And then when you calculate this, triangle is a little bit more expensive in the OR because you need a longer time, and sometimes you might need a little more blood for that. But when you then adopt this for the quality-adjusted life years, you can see the survival rates in this group are better with the triangle operation than the conventional open Whipple procedures. And this equals, after $50,000 that you are wanting to invest in a patient, and then the quality-adjusted life years the patient gains are worth doing this procedure, and it's finally cost-effective. This is certainly not what we should talk about in the first place. I mentioned just a little side aspect of this type of surgical technique. Now, the last thing I want to address very briefly is the so-called divestment. This is also some kind of mesopancreas excision, if you want to call it like this. This means, again, like the triangle operation, you approach the artery, you take some frozen sections. If they are negative, you do a dissection on the arterial wall, and you can do this right on the adventitial layer or even subadventitially. This is technically challenging, and you have to be aware that you might injure the artery. But also, again, here, with some learning curve, you can do this. Sign of arterial divestment is shown here. This is CT scan again after neoadjuvant treatment. You see the artery is surrounded by this tissue, and then in the OR, you can just take away this sharply from the artery, and you do not need to resect the artery. And finally, this is the specimen. You still see where the artery was in place, and the artery is saved if this is only connective tissue and not a true tumor infiltration. How to predict this before your operation? When you have your CT scans before the operation, you have two characteristic signs that, again, the colleagues in Baltimore defined quite nicely. Characteristic CT morphology after neoadjuvant treatment, and then can you do divestment or can't you do your divestment? They have defined this as a halo sign. If you have this halo around the artery, which means the artery is in shape and you just have a 360-degree halo around it, then you can do a divestment. If the artery is not in shape anymore, as shown here, the artery has an irregular wall in the CT scan, then probably divestment is not possible because there's a true, still persisting tumor infiltration of the artery. Halo sign and OR, I already showed you these pictures in the triangle operation. This again can be done sharply and the artery is saved and every tumor is removed. String sign, don't try to do this, you will injure the artery and you need to reconstruct the artery afterwards. When you have done it, typical pathological findings are this extensive fibrosis and this myxoid components after neoadjuvant therapy, but no true infiltration along the cut lines and at the arterial structures. So this is something to predict how your operative strategy should be, to be as radical as necessary, but not more radical with the price of an arterial resection that you don't want to do if not really necessary. So the question was, should we change our standards? Again, yes, we should. This is NCCN from 2023. What you see is, of course, again, the goal of surgery is a true R0 resection. This is not new. But what is new is that you should actually have these surgical procedures mobilize everything from the superior mesenteric vein as well from the superior mesenteric artery along the borders until the level of the adventitia. They explicitly state this in the NCCN guidelines, and then you have the maximum need for the patient, the maximum use for the patient, sorry, not need, that you have taken out everything radically, and this is nowadays recommended in the NCCN guidelines, so I think there's no discussion about that anymore, that pancreatic cancer should be operated like this today. So to conclude all of this, from my point of view, talking about the mesopancreas doesn't make really sense. It's no anatomical compartment, it is not defined. Level 1 to 3, yes, that makes sense. You have a benign condition, you don't need to approach the artery sharply. The triangle operation, yes, after neoadjuvant treatment, go on the artery, take it away. And the arterial divestment is even a more advanced triangle operation from my point of view. You really approach very sharply the layer of the adventitia or even below the adventitia, and then you can achieve this radicality we want to have as well as with the other operations, but a little bit more challenging. And therefore, from my point of view, systemic disease control is the job of the oncologists. We cannot contribute to that, but local tumor control is our job, and we should operate in the way that I just showed you in the last 20 minutes. Thank you very much.
Thank you very much, sir. Any question from the audience? Herhangi bir soru? Evet. Buyurun.
Soruları Türkçe soruyoruz değil mi?
Evet, veya İngilizce de sorabilirsiniz.
Tamam. Thank you very much, Thilo. I would like to hear your opinion about Ugo Boggi's paper. In-house mortality 2.3%, 90-day mortality 7.1%. So when you get that close to the artery, what is the main reason that they die after the discharge, which was median 12 or 17 days or so, I think?
Yes, they had 2.5 weeks of hospital stay, and these 2.3% were actually after the learning curve. That's what they called after the learning curve. I think they did 30 procedures defining as their learning curve. And these were the procedures where they did have this mortality. It was majority, I think, was bleeding complications to be expected in some way. But after these 30 procedures, they obviously improved and had this 2.3%. I think it's not the 90-day coming back patients, it's this learning curve thing that they show in the table.
Okay, then. I thought it was 70.1, 90-day mortality, but
that was in the beginning, as they write in the paper, and then after learning curve 2.3, of course, yeah, some kind of mathematics.
Evet.
Doktor Cemalettin Aydın, İnönü Üniversitesi. Sunu için öncelikle Doktor Bey'e teşekkür ediyorum. Benim sorum arteriyel rezeksiyonlarla ilgili. Arteriyel rezeksiyon yaptığınız zaman...
Pardon. Bir dakika, şey gelecek.
Do you have a translation? Okay.
Güzel sununuz için teşekkür ediyorum. Cemalettin Aydın, Malatya İnönü Üniversitesi.
Hello? Okay. Yeah.
Benim sorum arteriyel rezeksiyonlarla ilgili. Arteriyel rezeksiyonlarda ne zaman primer anastomoz, ne zaman graft kullanıyorsunuz? Graft kullanımında homolog graft mi, otolog graftler mi kullanıyorsunuz? Ya da sentetik graftler mi kullanıyorsunuz? Eğer graft kullandıysanız ya da anastomozdan sonra herhangi bir antikoagülan tedaviyi tercih ediyor musunuz? Tercih ediyorsanız bunun rejimini bizimle paylaşır mısınız? Teşekkür ediyorum.
Okay, thank you for this question. I have to answer in English, sorry. If we do arterial resections, yes, in most of the cases we can avoid a graft because the SMA can be approximated quite well. If you need a graft, I personally take artificial grafts, which I like to put on the iliac artery, just this ringed prosthesis or something like that, in a long loop from the iliac artery to the SMA. It's a good possibility. And for the anticoagulation afterwards, we do heparin and aspirin 100 milligrams for arterial reconstruction. It's the standard.
Evet.
Thilo, thank you for impressive presentation. I have a couple of questions. First of this, after triangle dissection, we have encountered more and more chronic diarrhea, persistent diarrhea. This caused to delay the chemotherapy, sometimes 3 months, 4 months. How to manage this? And this patients group, how to oncologic results on your series? Second question is, after periarterial divestment, how to protect to artery for late bleeding? It is how to manage this. It's so important because also we have encountered some divestment patients late bleeding. Thank you.
Thank you for the questions. I will start with the second question first. you cannot protect the artery for late bleeding. I think you just have to be sure that you have done your correct preparation with clipping and sutures. You can put some omental flap there if you like, if there is something, but I think this will not really prevent late bleeding. If you have some infection in there, the omentum will be gone away more or less. So I have no really standard for preventing late bleeding except for correct dissection technique, suturing, clipping, things like that. If there is bleeding, probably best thing is stenting, interventional radiology. The only thing you have to be careful is that you do not put the stent over the first jejunal loop which supplies the reconstruction loop to your bile duct anastomosis or Whipple anastomosis, then this of course gets necrotic. But good radiologists will fix this. The diarrhea, I have not experienced that many patients with such a long period of diarrhea that this would postpone chemotherapy. You have opioid medication, all of these things, all of this nutritional support. I think in many patients this resolves. There may be some patients it doesn't work, which can actually not come to chemotherapy. But from my experience, this is not very often.
Thank you.
Evet. Bu son oluyor.
Thank you very much for this nice presentation. So mesopancreas is very interesting. Like colon rectal surgeon, they are using this since 10-15 years, and now is now very good point for this. For mesopancreas, the defining the clear point is not very clear. The sites, you know, but we should to mesopancreas because we know the recurrence is mainly happening in mesopancreas after pancreatic duodenectomy. That's clear. So what can you tell us about mesopancreas? The definition of mesopancreas, the sites, which is not clear as far as I understand from your speak also. Thank you very much.
Yes, as I mentioned, the mesopancreas is, from my point of view, not a defined anatomical portion. This is just not like the mesorectum. So the mesopancreas is some kind of descriptive idea of all the soft tissue, from my point of view, on the right side of the mesenteric root down to the aorta between SMA celiac axis. Or if you approach from the left side for a distal pancreatectomy, of course the same idea from the left side. But it's not a, as I said, defined anatomical compartment. So I would prefer not to talk about the mesopancreas. It's just the soft tissue that you remove with the nerves, with the lymphatics, with the connective tissue, all of these things.
Okay, thank you very much, sir, again. No more question.